all these are with us, Dr. Winkler, to appreciate your participation.
Yeah, thank you very much, Professor Fadel. I hope you can hear me and you also can see my presentation. I'm not sure whether everything is working. Can you
Yes,
just...
yes, everything is okay.
Okay, fine. Thank you very much. Well, I'm very honored once again to be present in Cairo, a place where we always love to come and meet all these experienced surgeons and see all these complicated cases. We have heard a lot about the issue of charcoal food, etc., which is quite an issue. This becomes even more risky as soon as we have to deal also with additional infection of the bone. And we did not cover that before, but the most indication for amputation is the infected rear foot. And we know that we already have heard that diabetes worldwide in 2030 is expected to have 366 million cases. And in these, the diabetic foot syndrome is the most frequent complication. Also, about 20% of the patients and 6% finally are going to be amputated. And how can we avoid this? First of all, we have to see the Wagner classification for the characteristics, whereas the first two, 0 and 1, usually are always nicely to be treated in a conservative way. As soon as there's a penetration through the subcutaneous tissue that may expose bone, tendon, and or joint capsules, we already have risk of amputation, at least partially. And in the grade 3 osteitis, abscess or osteomyelitis, we have the most of the foot of the feet are going to be amputated already. We are concentrating mainly on the grade 3 classification, which we believe we can save quite reliably by using our special technique that has been developed in Vienna. We have dealt with infection of the bone already now since almost 20 years. And the key to all success is always to realize that infection is not done by planktonic bacteria, but mostly and especially in diabetic feet, there are multiple bacteria in one infected foot gathering together in so-called biofilms. This is already known since the development of Dr. Kosterton, who is a good friend of mine, and we already have several publications together on this topic. Biofilms are different than planktonic because they are absolutely tolerant against antibiotics and immune defense. And such, it is almost impossible to eradicate the infection in this foot simply by systemic antibiotic or other measures. It always requires a surgical approach. Reason for that is that these antimicrobial things do not get into the biofilm. They are covered in a glycocalyx. Which cannot be penetrated by the antibiotics. And as soon as there is some stress on these colonies, they go back into a tolerant state, that means there is no amplification, there's no growth of the bacteria. They just keep still but survive as long as there is any challenge from outside, and then they come back again. So to eradicate a biofilm embedded bacterial virus, much higher concentrations of antibiotics. And just this one example with staphylococcal biofilm, very easy one. You see, he's susceptible to almost all the antibiotics regarding the minimum inhibitory concentration, but the inhibiting concentration for these bacteria is not of relevance as soon as there is a biofilm. And you can see here, actually, we have to deal with the minimum biofilm eradication concentration, which is usually more than 1,000 times higher than for the usual MIC that we are familiar with. So we have to address these biofilms, and we can expect consolidation only when we have successfully combated it. And this is only possible when you have the antibiotics in such high concentrations, which are not feasible systemically, but they are feasible if you do it locally. If you place antimicrobials locally, when they have a bactericidal activity, long-lasting levels at the site of infections, and such, you can be sure that there is no systemic toxicity. We try to aim at that, and at the same time, we also have to address the bony defects at the same time and want to solve all these issues with a single stage. So if you want to avoid amputation, first of all, make sure that you know exactly where the infection is using MRI, bone scan, etc. You always should be aware that necrotic bone, dead bone, must be radically removed to reduce the bacteria, and you also have to take care that foreign material is removed completely. We never sacrifice vascularized bone. As soon as there is some blood flowing through the tissue, we always keep it. We just remove the biofilms from the remaining surfaces, use burrs for trimming down to bleeding bone. And when we have eliminated the dead bone, we have a dead space management, which must be filled. And for this filling, we use our specially designed antibiotic impregnated bone graft. So this bone graft is constructed by a thorough cleaning using supercritical carbon dioxide, and it is impregnated here with antibiotic solution. It is absolutely sterile. It is also sterilized by gamma irradiation. And for impregnating those tissues, we prefer local antibiotics that are badly resorbed. So what is a disadvantage in systemic use turns into an advantage when it is in local use. And so one example is vancomycin, which is very badly resorbed and such stays at the place where it is placed. It is the agent of choice for all gram-positive bacteria, including Enterococci, etc. It is not effective against gram-negative strains, and for these we have a special impregnation using tobramycin. It's the agent of choice for Pseudomonas, which is very frequent in diabetic feet, and it is bactericidal and has both of them have a very low cytotoxic effect locally. We have made these devices available also commercially since 2010. It's called osteomycin. It's a decellularized bone matrix with an impregnation of two different antibiotics, namely tobramycin and vancomycin in standardized concentrations. With this you can decontaminate the site after debridement. You same time reconstruct the defects that have been caused by infection or debridement, and all this tissue can be incorporated completely and turned into own bone after several months or years, depending from the size. I hope this
You can comment by your voice because it is too low tune.
there is no sound.
Yes, you can comment by your voice. You can give us
Okay,
just the conclusion at least.
this video. Well, we can't go for the next one. I'm not sure whether you could understand this video from before.
No problem. Yes, no problem.
No problem. Yes.
No,
Is it,
yeah, you can go on. Yeah.
If it is clear, I'm very happy on that. You see that there are different phases of the elution kinetics of the antibiotic locally, with extremely high concentrations at the very beginning, eliminating all biofilm remnants, and more tolerable concentrations later on for complete reconstruction of the bone. The typical case, as we have seen in diabetic feet or in Charcot feet, is the fourth ulcer, the plantar ulcer, and penetrating to the metatarsal head with accompanied osteomyelitis. This is the typical case, but usually it is not really in danger of an amputation. You can see here one of the typical cases with the large destruction of the second ray of the forefoot. And of course, in this case, all the necrotic tissue has to be removed. First of all, we always have the approach from the ulcer side, so usually from plantar, and excision is mandatory of the ulcer. From there, we go for the debridement. We remove everything which is necrotic and infected. The rests or the remnants of the metatarsal head, they are resected and removed. Then we curette the diaphysis of the metatarsal, rinse the whole area thoroughly, and then we fill the defects inside the diaphysis with our antibiotic bone graft, usually using a mixture, because we almost always face multimicrobial infections. So we use Winkler and Toba, usually in a mixture of 2 to 1. And afterwards, we care that the wound is completely closed, never leave it open. So during that time, after the closing of the wound, there's an antibiotic release from the medullary cavity. And these are uncomplicated cases usually, which have only very, very short treating time. You can do these in a one-day surgery and leave the patient home. And in this case, amputation never becomes an issue. It's much more difficult when we consider the rear foot. In this extraction, these are extremely difficult to treat, and these are the ones which very often or almost usually end up with below knee amputation. In Germany, there are 60,000 amputations per year, which we believe most of them are completely unnecessarily. They can be solved with our technique. The only thing which is required is that we have a sufficient vascularization. So a gangrene, because complete closure of the arteria is not an indication for that. Of course, what is dead must be removed, and this is the only indication for an amputation for us. This is one case where, according to the Charcot, it was comminuted. There was 32 operations already done and completely unstable. You see a typical mixture of bacteria consisting of gram-positive MRSA and gram-negative Klebsiella. We have reconstructed this refoot. You can see here, this area here is a complete reconstruction using our bone graft, and we stabilized with those screws. And this is the idea 4 years post-operative. There is complete, fully weight-bearing. Infection was not visible on this. There is already reconstruction, revascularization of the grafted bone. However, when you look very carefully in the MRI, large parts are completely integrated, but in the middle you will still find some remnant or recurrence, we don't know, of an infection. And there was some fistulation, as you can see here. However, this didn't mean a gross infection. The patient itself was pain-free. The foot was stable, and he was completely weight-bearing. And this requires only just a small fistulectomy, local correctage, lavage, and the patient was in hospital just for 1 week after that. Another case, a real B host with multiple operations before, also having MRSA plus gram-negative pathogens. He had vacuum treatment, antibiotic B-chain closure, but still didn't work. He had a massive infection with septicemia. The CT scan shows this large osseous destruction in this area. And we excised all the soft tissue. We made a complete necrosectomy of the bone down to the bleeding bone. We do not sacrifice bleeding bone, only dead bone is removed. After that, we have cleaned everything using a jet lavage. This is a pressurized lavage, so that everything is going to be absolutely clean. You see, as soon as we have some bleeding bone, we stop the removal and just keep it. And this is also the idea that we have to stabilize this situation, as we already have heard before. And in this case, we used a locking plate, a so-called NCB, as an internal fixator. These are angle-stable screws, so that we have a stability, rigid stability. And the defect that you can see here, we have filled with our impregnated bone, so that we had a reconstruction of this side. This is done by so-called impaction grafting. You just hammer it inside so that you also have some additional stability. The soft tissue had to be covered by a flap. In this case, it's a Suralis flap. And you can see the result 6 weeks after the surgery. There is no sign of infection. Because we used this plastic surgery, we had 2 weeks of bed rest and 3 months partial weight bearing. can hear the post-operative result. After 1 year, you can see here the reconstructed area. It is already, the graft is already incorporated. There is no limitation around it. It is not yet remodeled. It requires some months or years until it becomes a real own bone with the structure typical as you can see it here. But it is already fully weight bearing, and the patient is absolutely mobile without limitation. 2 years post-operative, you can follow that there has been some condensation of the grafting bone during incorporation, visible by this broken screw. However, it is still absolutely stable, and the patient can walk without any support. He even refuses to wear orthopedic shoes. This is the result 3 years post-operative. So, in summary, I just want to point, we are talking about infected feet with difficult osteolysis, especially in the rear foot. And for starting a good treatment, you have to do a very exact localization of the infection before you start with the operation. You should always aim at a radical debridement of the dead bone. Don't sacrifice vascularized bones, which is quite important. We can repair our defect or these defects with our impregnated bone. By polymicrobial infections, we have a fixed combination of Vanco and Tobra between 2 and or to 1 or something. Always do some kind of stabilization. You can do this with an internal fixation, or you also can do it by using an external walker for a few months. This is a possibility. We do more and more just with external walkers. What we also have to emphasize, to do this technique, you need an airtight closure of the wound. So don't leave any ulcers or whatever. And to cover the soft tissue, sometimes you need a plastic surgeon. And I'm very happy that we have an excellent plastic surgeon in our team who is doing all those flaps, if required, also free flaps. But usually things take-home message. Bone infection by itself is not an indication for amputation. That bone must be removed radically. We can reconstruct the defects in the same stage during the same operation using our impregnated allograft bone. So this is providing higher local concentration of antibiotics, which even can eliminate biofilm remnants. Internal stabilization is feasible at the same stage, so don't have to wait until the infection has been cleared completely. Recurrences may occur, but they can easily be treated with a very simple operations. And we will talk about this even longer in our next meeting of the World Association against infection in orthopedics and trauma. This is this year taking place in Miami Beach. And I hope we can welcome as many as possible to our meeting in Miami. Looking forward to see you. Thank you very much for your interest.